All right. Well, thank you so much for joining me today for this presentation. Like Keita said, my name is Claire Farless, and I'm with the Upper Cumberland Area Agency on Aging. I have been in the Family Caregiver Program now for 12 years, or excuse me, at the area agency for 12 years, and I've been in the Family Caregiver Program for 10. And one of the places that I have been specialized in training is dementia care. So, what I'm getting ready to present to you today is a positive approach to dementia care, which I have been taught by Teepa Snow, this approach. So I am going to go on to my next slide. Give me 1 second. Okay. So I have to acknowledge Teepa and what she does. So this is Teepa Snow's vision, and her mission statement up here on our slide. This is positive approach to care is the model that she teaches. If any of you are interested, I encourage you to go onto her website. They are currently holding their trainings for coaches, trainers, and consultants. They're doing this online, so there's no need to travel. She will come right to the comfort of your office. So this is a wonderful approach that she has came up with. Teepa spent over 30 something years working for Alzheimer's Association in North Carolina. And through her a partnership with them and also her background being an occupation therapist, she came up with this type of approach. As Teepa says, she spent many years tormenting old people. So hopefully that will not be the case for you all moving forward. So, things you need to know about dementia. All the time I get the question, what is dementia? They have Alzheimer's disease. Is that dementia? Well, yes and no. Dementia falls under an umbrella of many different types. Alzheimer's disease being one of the many types. Currently, I have heard that there are anywhere from 90 to 95 different types of dementia that our loved ones may be suffering from. So you kind of have to be on the lookout for what type. Also, with dementia care, there are things that may look like dementia as well. We call those pseudo dementias, and some of the things that can appear as a dementia, but once that condition is taken off of that individual, then their mind will clear up. So some of those include depression. Severe depression in older adults can lead to dementia-like symptoms. Also, one of the most common that we hear about of a pseudodementia is the UTI. When a loved one gets a UTI, especially at an older age, unfortunately, the way it affects their brain can come off like dementia-like symptoms. Could be irritability. It can also look like them forgetting things. They're not thinking clearly. So that is also a big indicator. Usually that's the first thing that I ask my clients when they're telling me their loved one is starting to show signs of what they think might be dementia. I ask about the UTI. Now, a little statistic about the UTI, or a fun fact about the UTI, is that with people that have dementia and older adults, sometimes the test that they give for a UTI does not actually show that they have a UTI. For some reason, it may not show up in that older adult or the one with dementia until 48 hours after the first signs have happened. So if you get them in to the doctor immediately and the doctor tests them and it's showing no signs, well, I encourage you to test them again within 48 hours of that first test, because it will show up then. So just, things to be aware of. I would like to think that those in our medical profession may be aware of that, but you also have to consider that if you're going to a general practitioner, they have a lot of things that they have to put in their wheelhouse. So they may overlook that detail. So as professionals and as caregivers, that is something that we have to advocate for. Other things that can appear as a pseudo dementia can be medicine interaction. So your loved one has a new medication and they're starting to be confused. Maybe it's interacting with a current medicine differently. So that's something else to be on the lookout for. Pain, nonstop pain, can also cause the look of dementia in a loved one. So if they have a source of pain that is not being treated, then that can also appear as dementia as well. There are several other things too, that can also cause pseudodementias. One is like delirium. In our field, we've called this white coat syndrome. So sometimes when we take our loved ones to the hospital for treatment, or maybe even we have to admit them into a nursing facility, because of that environmental change, it can cause stress to the brain, and it can also look and appear like dementia. Sometimes, even if they do have dementia, it can make it worse. So, those are just some fun facts to kind of know about dementia. So, let's talk about the people that actually have dementia. So, 50% of the people that do have dementia have no self-awareness. So like up here in my little in my slide, you can see this 50%, and in the picture, who is this looking back at me? They have no idea. They have no idea that they're taxing you, that they're wearing you out. They just don't they don't like or excuse me, they don't have the awareness that that's what they're doing. So they're going to act in two different ways. Half doesn't realize they have it. The other half that does realize that they do have something's going on, they may not be able to call it dementia. Maybe they're just like, I'm having problems remembering. Well, then that group, of that 50 group, they will act of one of two ways. So of the 20%, these are the folks that have always been strong, and they're aware of their own skill set. So they may be aware that things are not going as they should. But they will also have a tendency to hide this from other people, and they don't want others to know. They're the ones that are very private, and also they're also the ones that we have to be on the lookout for, because they will try to isolate themselves away from people. For them, they do not want to ever appear that they have lost those skills. It may be a little bit of pride on their part, but we all have that, unfortunately. So that is the 20% that may appear of having dementia. Now, and then the 30%, these are the folks that realize that they have dementia, and they can be like the 50%. They can be consistently needy. And what they do is they basically latch on to the caregiver. They know that as long as that caregiver is there with them, that they don't have to worry about messing up, that they don't have to worry if they forget, or maybe their speech comes out garbled and they don't make sense. So that 30% can be very taxing on a caregiver. And in that 30%, we strongly recommend that you build your team as soon as possible, because those are the individuals that are going to wear you out. So for caregivers and even professionals, you've got to encourage that building that team, because we say in this type of in caregiving for those with dementia, we may forget who you are, but we're never going to forget how you make us feel. So that is just something for us to be very mindful of. Also, they stay connected to loved ones to ease into new relationships. So that's why building that team is so crucial early on. You want to help ease them into new relationships earlier in the process. That way, later in the process, when maybe you're more taxed by the caregiver's behaviors or just the care requirements itself, you have what they call the bandwidth to take that effort to build the team. So early team building is crucial in this type of care. The next thing that I want to talk about is the caregiver agenda. So with the caregiver agenda, what we have a tendency to do, like the picture says, we have a tendency to take our agenda and just smack people in the face with it. We do this to people we're caring for all the time, and it may not be, it's not, I would like to say it's not intentional. It may just be a necessity to get things done. As a caregiver or even a professional working in the care field, we have many things that we've got to get done throughout the day. And sometimes it's easier just to grab that person, throw our agenda in their face, and then drag them along with us. But what happens when we do that is eventually the person we're taking care of with dementia is going to start even not even they may not even have dementia, just care recipients in general, they're going to start fighting back at some point. So, we say with your caregiver agenda, you have to know your agenda, but not show your agenda. So again, the biggest mistake is not being very clear about where they are starting their care recipient. That is one of the biggest mistakes that we make on our caregiver agenda. We have to step back and acknowledge that things are changing. So many times we run into caregivers that are just in denial about what their loved one can do. And it's heartbreaking. But we as professionals have to find ways to explain it and bring them back to a realistic expectation of their loved one. We don't need to point out their incompetencies, what they can't do, or remember. Telling you to remember something is, I'm like, as soon as you tell me to remember it, I may just immediately forget it. And that's me. And I don't have, I'm not in brain failure, unlike some of our people that do have dementia. So we have to make sure that, with our agenda that we're realistic and where they start. And also the reality orientation too. We've got to make sure that we do not do reality orientation as well. So that is sometimes hard and it takes practice. I can't tell you how many times that I've said, "Oh, remember?" And I'm like, "Oh, Claire, you've been trained. You're not supposed to do that." So it's so easy to fall back on what we know. So just know that it does take practice. Also, how many times have you run into caregivers and care recipients that they're both in an argument over who has to be right? Well, when we're caring for someone with dementia, it's like arguing with a wall. Right now, I want you all to look at that wall beside you and ask it to go open the door. And those of you that it does happen to, please let me know because we need to record that wall opening that door because that's phenomenal. So we need to record that. But that is like the same thing. We're asking someone in brain failure to do something that is impossible for them. So we have to realize that that they are not able to think. You can't rationalize with someone with dementia because of what's happening in their brain. Also, in the caregiver agenda, we have to create a relationship for the moment. But to do this, you have to let go of the old relationship. And that can be very hard because in order for us to let go of that old relationship, usually we have to have space and time away from that individual to heal. But unfortunately, sometimes with our caregivers, they don't have the luxury of saying or having that space. So not only do they have to deal with what's currently happening with their loved one, they also have to deal with what we call those emotional hooks. So for example, if your mom that you're taking care of that has dementia and she's always asking you where your older brother is, even though your older brother passed away from a horrible car accident in his teenage years, even though that's hard for you to bring up that memory, we have to be able to take away that emotional hook so that we can create that relationship for that moment. And that can be very hard for a lot of us. So just remember again, as I'm telling you to remember, I maybe should say be mindful, know your agenda, but don't show your agenda. And the same when we go into a home, when we're helping caregivers, we don't bust up in there saying, "Hey, our goal is to get you qualified for long-term care so we can get you in a nursing facility so we can do this, this, and this. That's our agenda, but it may not be the agenda of the person that we're working for as well, and especially if they have dementia. So let's talk about 4 truths about dementia. So, first truth, very sad, but at least 2 parts of the brain are actively dying at one time. So, this can be very hard for caregivers and sometimes us as professionals to see that person in that brain failure, but we have to step back and do that. Also, that dementia is chronic. There is nothing at this stage of the game that is going to stop it, get rid of it, or turn it around. What we have right now are medications designed to reduce the symptoms, and that only unfortunately works with a small group of people. So medications are not our fix all, unfortunately, with this type of disease. Our third truth is it is progressive, that eventually it's going to get to the point where it's going to basically kill their brain. It will eventually keep attacking the brain until there's nothing left. It is currently the 5th leading cause of death in the United States. So it's only going to get worse. And last, that it is terminal. It's going to result in death. Like I said, it kills so much of your brain that it can't keep going. And by the time that you or the person with dementia passes away, they only have 1/3 of their brain left before they die. And that's very unfortunate. Also, to get a true diagnosis of dementia, and I don't know if they've changed this recently, but you have to have this, a true diagnosis comes upon autopsy when they're actually able to see that person's brain. Usually when you get a diagnosis of dementia, it just means that the symptoms are in place and that they're actively showing those signs of being in brain failure. So very sad. Also, another thing, another truth of dementia for the caregiver, because of the stress and duress that they're going through, it puts their mind in a state of mild cognitive impairment, and they don't realize this. So, for all of us, if our mind is in a state of stress and duress for more than 2 weeks at a time, then our brain permanently kind of changes the pathways. We have other like grids that come in that form in our brain and how we adapt to that stress. Also, sometimes I have caregivers that say, I think I'm getting it too, I just can't remember. And that's an indication to me that they do have too much stress on them. And that's why respite care, and you all know this, why respite care is so important, to give their brain, their body, their emotions a break and allow them to that stress to be relieved for them during that moment. I don't know if any of y'all are familiar with a program called ACEs. That's Adverse Childhood Experiences. And if you ever look at the brain of that child when they've gone through that trauma when they were little, their brain actually forms into mild cognitive impairment. You see that on the outside on the brain scan. This is nothing that I have actually heard statistics or doctors on, but what I'm going to say is my opinion. I feel like that might be why we're starting to see dementia earlier, being diagnosed in our late 20s and early 30s. We're starting to see people diagnosed with early onset of dementia. And my opinion is, what's happening in the childhood, that childhood trauma that may have already set that person into place where their brain already hasn't formed to where they can handle a lot of stress. Then you add the stressors of maybe taking care of a parent, school life in general, and it puts even more. So that could be a cause, and we just don't know. There are a lot of factors that go into an actual diagnosis of dementia, and not being a complete medical professional, I'm not going to go into that here, but just food for thought. So also talked about another truth of dementia is in the later stages, we start to lose our skill. So on this diagram, you see what I have labeled as our skill fingers. That's your thumb, your index finger, and your middle finger. These are all skills. So think about when you open a bottle of water. You're using those main two or three fingers for your skill because that's fine motor. And, when you add in dementia, unfortunately, those skills start to change. So when those skills start to change, all of it becomes strength. So your whole hand, that person, their whole hand becomes strength. So not just the this finger and your pinky, all of this turns into strength. So why is that important for caregivers to know? Why is that important for you as a professional helping our caregivers to know? The reason is your little old maybe Miss Betty, the sweetest lady in the world, 94 years old, has dementia, grabs hold of your arm and starts to squeeze. That 94-year-old, because of what's happened in her brain changes and the way that her skill has now turned to strength, could break your arm. I had an intern that worked in a nursing home, and when she was going through this training, she shared a story about a client that she had in the nursing home that she grabbed hold of one of the aide's breast and she squeezed so hard that that aide actually had to have her breast removed and had to have reconstruction surgery. So it's there. The strength is, so that's something also to be mindful of as well. So in also those later stages, there are other changes that happen too. So strength is a big one to be aware of. How many times have y'all said this? I can't remember what I went into the room for. Is this normal? I can't remember where I placed my keys. So let's kind of go into what is normal aging. So what is normal aging? Well, first of all, I have a picture of filters up there. Well, as we age, we lose our ability to filter out things that we shouldn't say. So kind of below, you see my little comments and you see the X, because we will make comments that aren't appropriate. We may tell someone that their shirt is ugly. We may yell out during the middle of church, during the middle of a presentation, something that shouldn't be said in that group setting. Because our filter is damaged, we will unfortunately make those comments. So that's just normal aging. And unfortunately, those of us that have ADHD, we already have a damaged filter as well. So as we age, our filter is basically just going to be non existent. And that can cause a lot of trouble later down the road. Also, part of normal aging is we're slow to think or to process. So that's why I've got our little turtle up here with our little speed index on here. We're just slower to think and it's slower to word find. So one of the suggestions that TIPA gives us about this, so when you're talking with someone and they can't find the word, what we need to do internally is to count to 3 to give them that opportunity to find the word. So easy, so many times it's easy for us to want to go ahead and answer it for them, but we really need to allow that person the opportunity to do that word finding. They look before they leap. So, like our little ballerina here, before they take off and leap into a big big decision. Maybe it's going on a trip, selling their home. They're just more cautious before they leap as well. We've talked about pausing to word find. New data here. New data reminds them of old data. And so when we have something new and improved that comes in, we can relate it to something we've already seen, and then we file that away in our filing cabinet in our brain. So that is some of just normal aging. But what is not normal aging? Okay, so what is not normal is the inability to think the same. I just can't think clearly. Um, I don't know if any of you've ever experienced a concussion, but unfortunately, this summer I experienced that, and I could tell that my brain was not thinking clearly. Things were different, and I at least had that self awareness. So, not normal aging really, what I give an example of this to my clients is, it's when you go to use something that you've always used. A great example is to get into your car. When I pick up those car keys, if I forget what those keys do, then that's when we're having a problem. That is not normal aging. When I pick up an object and I'm not able to figure out what it goes to, and I normally would have, that can be a problem. Also, we get stuck in time. Like up here in the corner, we have been stuck in time. So, we call people with dementia time travelers. They will time travel back in the order that the memories have. That they've gained the memories. So, usually by the time they get into the later stages of dementia, they're only remembering those really earlier stages of life. And that can be very sad for couples that are maybe this is their second marriage. And as that person time travels, they may forget who their current spouse is and may remember the first spouse. So it can be very hard on a caregiver taking care of someone. But that is that's not normal aging. Also, the inability to successfully recall a person's identity. And I've already heard all of y'all say, "Oh gosh, I can't remember names." That is not what we're talking about. What we're talking about is, say you have seen me every day for the past 12 years. And next thing you know, I come in and say hello to you, and you don't recognize who I am. That's not normal. And then that is where we have an issue. Um, Also, they're not able to recognize, like I said, the old data. So what is so something new brought in, they cannot make the correlation with the old data. So that is very hard for them. A great example is our cell phones. We have gone to basically, we have a computer in the palm of our hand. And if I gave a brand new cell phone to someone that with dementia that's only had a flip phone, they may not know what to do with it. They're like, well, what do I do with it? They may try to, they may look at it as a calculator. Maybe it's a TV remote. So usually how I explain this to my clients is think of a filing cabinet. When we get that new data in, we're like, okay, new cell phone up, that took the place of my flip phone. We put that in our filing cabinet. Well, when you start to have dementia and the not normal aging, what happens is you take your filing cabinet, flip it up, and let everything just fall, and then smush everything back together and put it in those files. So, what can happen there, kind of like the example of the cell phone with the remote, we don't correlate that. So, when I go into my filing cabinet, cell phone, cell phone, cell phone, there it is. And we bring out TV remote. And that's what we try to use for to make a phone call. So, that is our not normal aging. So don't worry if you forget where you parked your car at Walmart. Don't worry that you can't remember the name of that new intern that's working with you. Just be concerned if you go to do a task that you've always done and you can't remember how to do it, or if it's a person that you should know, but you can't remember them. So that brings me kind of into a little bit more too on us in general. We have 5 ways to get information in. So we have our visual processing, so that is what you see. We have our auditory processing, and that is what you hear. We have our sensory motor processing, what you touch and feel. And that part that controls those are on the sensory motor is on the top of our brain, and it is hardwired in. It's also some of the last things that go. And it also is where we keep our rhythm in that sensory motor. Um, in the late stages of dementia, you are going to have issues with your smell and taste. I'm sure this is a common phrase that you've heard with your clients. My loved one only wants to eat sweets. Well, the reason for that is because with the dementia and as it progresses, they lose that ability to taste. And unfortunately, sweet is all that they can. So, it's not too much of a problem if they're not a diabetic. But if they're a diabetic, that becomes a huge issue when that's all they're wanting to eat is sweets. So I had a caregiver that had to lock up all of her sweet things into a cabinet to keep her loved one from getting to those. So unfortunately, that's all that they can taste. Also, smell. Your smell goes. So in the later stages, where this comes into play is food that has spoiled. How many times have you heard caregivers say, I have to be careful what's in the refrigerator because my loved one will eat it? Well, absolutely. They're in late stages of dementia, so we know that their taste has changed. And now they can't smell. They can't smell the fact that that piece of pizza maybe has been in the refrigerator for a month and it doesn't smell good, nor does it taste good, but they're going to eat it anyways. So that is a huge thing for our caregivers to look out for. An other side note on that as well, think about cleaning supplies. What does a cup of bleach look like? If you're using bleach and you just have it in a plain glass, my grandmother used a plain glass for our bleach growing up. And I think back now, like if I wasn't in the right mindset, I could easily pick up that glass of bleach and drink it thinking it was water, or depending on what color some bleaches have a little bit of a yellow tint. I may think it's a tea or something along those lines. I do not smell the bleach smell, nor do I taste it. And that can come into a huge problems down the road. Bleach is not good for us to digest. Another example that I give them is Windex. What does that Windex look like to you? It's blue. Blue Windex could, in their brain, remember their filing system is messed up. Blue liquid, they could think in their brain that maybe that's Powerade, maybe that's a sports drink. And you're like, well, but you think they should know because they had to unscrew the cap just to get that, just to take a drink of it. But remember, you have to remember, because you're not in brain failure, because you've got to remember for them that they cannot distinguish what their some of their tasks. So even though they had to unscrew that to take a drink, that there's still no safety awareness going on there. So those are some issues that we have to be aware of for our clients and to share this information. And that being said, let's talk about, some of the places where our information comes from. We've talked about a little bit of our sensory cortex and our motor cortex. The frontal temporal lobe, this is where we find our safety awareness. And unfortunately, that is the first thing that goes. So what does your safety awareness help you do? It helps you to keep from making those mistakes, from drinking the cup of bleach, from getting in a car and driving when you're not physically or able to. Also, it affects their wayfind. So many times I've heard caregivers say, well, I know that they aren't thinking as clearly, and they do have dementia, but they can still get in the car and go down the street to church. Well, that's fine until they have the moment where they can't find their way back home. And that's where it comes an issue. And for caregivers is that allow their loved one to drive, it's just a ticking time bomb. When is that going to take place? When they can't remember how to get back home. So that's in your frontal temporal lobe. Also, with the safety awareness, it doesn't finally finish forming until the age of 25 for females. Men, no offense to you all, but usually for men, it doesn't complete forming until the age of 30, or excuse me, 28 to the age of 32. So men has a little bit more of a threshold of that forming. And why this comes into play for us is because with dementia, you lose it in the order that you gained it. So that safety awareness, that wayfinding is the first thing that goes. It's also their ability to reason and to be reasoned with. That is why we can't, it's hard for us to reason with someone with dementia, because their brain will not allow it, will not allow that to take place. Also, on the left side of the temporal lobe, which you can see here in the yellow, this is appearing from the right, but on the left side of it is where it manages our language. And for 93% of the population, that is where our language is affected. So we lose, when our language, that center is damaged, we lose the ability to have good vocabulary, comprehensive speech, and speech production. That is why sometimes we have clients that their words just don't make sense. They are kind of garbled and pushed in together. That is why we have those issues. Also, what happens with that on the language center is that in the early stages with dementia, you miss 1 out of every 4 words. So imagine me having this presentation with someone with dementia and them only hearing 1 out of 4 of my words. Imagine how confused you would be if that's what you are hearing. So, also, what we have to keep in mind, this is a Alzheimer's brain, and on the right side here or of the screen, you'll see how dementia and Alzheimer's disease is affecting this brain. Why this is important is we want to look at the hippocampus. So the hippocampus is our learning and memory, and it also controls things like our emotional memory. And it also, so in our hippocampus as well, we have our amygdala, and I'm going to go over that here in just a minute. But so I wish that we could actually see the person's brain with dementia when we're caring for them, because I think it would make us more understanding. With this type of disease, it's not something that shows on the outside. It's something that's more internal. So, all right, guys, I want you to kind of remember this tune. We lose on the left, retain on the right. Okay. So again, talked about some of the changes that we lose on the left is that language, safety awareness, ability to rationalize are also things that we lose. What do we retain? Let's talk about the good things that we retain. Okay, so we retain on the right, and what we retain on the right is our social chit chat. That is why you can walk in, talk to someone, hello, how are you? It's almost automated. Sometimes I know that we've done this in passing in the hall with some of our coworkers. Hi, how are you? And maybe they don't say, how are you? And you just say, good, thank you. And you and you move on, and that's our social chit chat. But once we get outside that social chit chat, we can actually start to tell that there might be an issue there. Sometimes, we really have to be that detective, and we really have to look for those changes. Also, we retain forbidden words. So this is why also that we hear cuss words coming out of our relatives that have never cussed a day in their life. That's why they can drop a 4-letter word and it not be a big deal to them, and they don't even understand why you're getting upset. A good story for this in my own personal life, my Aunt Dixie was married to a Church of God minister, and she had started to develop dementia. And one weekend, her daughter had came in and also married a Baptist minister, so very strong in their spirituality and religious beliefs. They come in, and Aunt Dexy goes into her bedroom, gets dressed from head to toe, because this was back, in the 60s, where, they just dressed very polished. She got her purse and her little gloves on. And my Aunt Ruby said, Mom, where are you going? I'm going down to the church, to that class where they teach you how to beep. I'll let you insert the word there. And Aunt Ruby almost passed out on the floor when she heard her mom say that, not knowing that, that was part of the dementia. So it does happen, and racial slurs as well. Unfortunately, growing up in the South, sometimes with my own father, who has late stages dementia, he will refer to people in unkind terms, but that's what he grew up hearing. So those racial slurs, sex talk is big as well. And for those of you taking care of patients, especially in a nursing home setting, it's good for us to know this. So if they can't keep from saying, "Hey, you got a nice body," and they start going into graphic detail, if we don't know this about them, what happens? We label them a pervert. We label them a deviant, and maybe in some cases and when this goes on, it might even result in them being kicked out of a nursing home for inappropriate behavior. But that happens. Um, Going back to my slide that I had the hand up as well. Also, what I want you to know with the changes in the later stages. So this is our sensory. These is what we feel and touch as well. Our tips of our fingers are very heightened in sensitivity. You'll see sometimes people with dementia turning their arms, or doing this with their arms, wringing out their arm, basically, and it's a sensory thing. They may be touching. They may walk up to someone that has on a nice furry shirt and touch and stroke it, and that may not be most appropriate, especially depending on where they decide to do that. But they have no awareness that this is happening, so they're not able to make that distinguish between appropriate and inappropriate behavior. Also, one of the things that this comes into play with too, mouth. So the mouth is very sensitive too. And remember, they're losing that sensation also in their growing area. So what you have to be mindful of with this is why you have patients that will go number two on themselves and play with it, because all their body tells them is that I have a warm sensation in my private area. That's interesting. They go to check it out because their fingers are heightened in sensitivity. Oh, this is weird. This feels, is this Play-Doh? Oh, must be Play-Doh. Doesn't smell like anything because remember, you remember, they can't smell. So this is why these kind of things take place. And I tell caregivers all the time, do not think that they've turned into some huge deviant because they may be starting to play with themselves. And that is a hard thing as a caregiver to have to deal with, and maneuver that behavior. So what do you put in place to help them? That's why activity blankets are very crucial. That gives them the texture, the motor sensory. Weighted blankets are very helpful. You really have to be a detective in their environment. Also, moving on, the other thing is that we retain rhythm. So the part of our brain that has that music part that retains the rhythm is one of the last things that go. So how that is helpful for us as professionals and caregivers is that maybe when we have someone that's not hearing our speech, because remember, they're only hearing 1 out of 4 words, we could sing the directions to them. And if you're like me, you really don't want to sing, but you want to get that point across. Maybe it's just that you talk in a rhythmic tone, So you have to play around with your tone as well. But rhythm and music is really important to dementia care for us to use as an intervention. They will remember songs that they've heard as a child, songs that they have an emotional attachment to. Prayers. A lot of us, we could quote the Lord's Prayer without even hesitating because we've heard it so much. A great example of this is the Pledge of Allegiance. I have been taught the Pledge of Allegiance since I was in elementary school, and that is something automated in me that will kick in that I can recite that song easily and know the words as well. So we remember we lose on the left, retain on the right. Yep, just making sure that's right. I'm also dyslexic, so if you see me pausing, I don't have dementia, at least not yet, I hope. It's just me trying to figure out what side of the brain I'm needing to use. Um, Also, just some things to keep in mind for early stages of dementia. 9 out of 10 times they do not know that they're not making sense. So they don't know that what they're asking you isn't making sense to you. And that's why you can have people that get very frustrated and violent at you when they're trying to ask you a question and they're not making sense to you, but they don't know that. They think to you, they have asked you to go to the bathroom, and all they know is you've smiled and set them in the corner. Well, can you imagine the frustration on being able to being not being able to communicate with someone and them just smiling and putting you in the corner, or worse, getting mad at you, and maybe it's getting mad at you and putting you back in your room, whatever that might be, so we have to be understanding of that as well. Also, many people will go mute when they realize that they're losing their language skill. Because again, when we go back to that one of the slides in my earlier presentation of the people that realize it, um, they'll go mute because they do not want to show that they have this issue and then it's becoming a problem to them. Okay. Moving right along. Also, bringing back up the brain, some other things I want to bring your attention to on the frontal lobe. Again, that's your impulse control, logic, sequencing, and decision making. That the sequencing is important for us to realize because that's why you can't say, "Mom, here's your clothes to put on. Go ahead and put your clothes on, and then come downstairs for breakfast." Well, there's a sequence that goes into play there. Maybe you've already got her dressed and all she lacks is putting on her sweater. And you leave the room and she's like, okay, okay. And then she's like, what was I doing? There's the bed. There's my pajamas. Ah, I'm getting ready for bed. And so she persists, takes off her clothes, puts on her pajamas, gets back in bed. You wait a while and you're like, where's mom? What is she? She got lost up there. And you go back up and she's in bed. And if we are not aware of what's going on in their brain, that can completely ruin our day. We can, Mom, what are you doing? You're supposed to get dressed and come downstairs, and we have a hard time understanding that they can't sequence. So for us, and we have to just be patient and understanding, and these are very important skills to pass on to our caregivers. Optical lobe, again, is in the back part of the brain. This is also where our long-term memory is, and this is one of the later things that go in the last stages. Again, that's why we say they time travel. It's also why they have more of they remember when they were a child and not necessarily what happened last week or just an hour ago. So keep that in mind as well. All right. Also, okay, I kind of mentioned the HIPAA and the amygdala earlier. So in my next, we're getting very close for me to show you the actual positive approach to approaching someone. But what I want you to keep in mind is this slide, okay? So you have your hippocampus, and in your hippocampus is your amygdala. What does your amygdala do? Okay, that is your fight, flight, or freeze. So those of you that go in to help, maybe you're in a nursing facility at home, you go in to get your loved one up out of bed. I'll talk about the approach here in the next slides, but we scare them. In our interaction, we may unintentionally scare them. So when we scare them, we stimulate their amygdala. Okay, so that's why caregivers sometimes get punched. That's why care recipients get agitated. There's a whole lot of things. Maybe they freeze and won't even move for you. But once that amygdala is stimulated, they cannot pee or poop for 20 minutes. So think about that in a nursing facility. We come in, we've scared the bejesus out of them, we've got them out of bed, spent about 10 minutes getting them out of bed into the bathroom. Because of our schedules, we are in a hurry. We have 24 more people to do to get up and get into to get to the bathroom. Or as a caregiver, we have a ton of staff, a ton of tasks to do. We have laundry, whatever. We set them down there. We come back in a reasonable amount of time that we think. But remember, they get stuck in time. So if you come back in, let's say an hour, they may think it's only been a couple of minutes. So you come back and they're like, what? I tried. Okay, I guess I don't have to go. And so you get them back into bed, get their clothes, whatever. 20 minutes has passed, and guess what happens? They go to the bathroom on themselves. It causes that frustration. And so as caregivers, if we will practice this positive approach that I'm getting ready to show you, even as professionals, this will help us. This will help us not stimulate their amygdala. Okay. As well. So a few more things I want to touch on before I go into that is our vision. Vision changes that take place. So at the age of 25, all right, and no one can see y'all, you have your cameras off in your office, put out your arms like this. And you may not be able to see all of my arms, but they are there, I promise. Okay, so as we age, we have our peripheral change. So at age 25, our peripheral is here. As we age, it will come in. By the age of 75, our peripheral will narrow 45 degrees. So we are not able to see out of our sides, okay? So that is why when you come up from behind someone with dementia, or even just an older person in general, we will startle them. And we don't want to stimulate that amygdala because we know what can happen, right? So our peripheral changes. Our peripheral basically will come in, but when you add early onset, you get what we call tunnel vision. So again, we can't see you. Put on your scuba mask, okay? And just look around. There's a big difference in your peripheral vision and what you can actually see. And so that comes into play. That's why, too, with age-related changes, that's why driving can be a huge issue that us as caregivers and as professionals have to address with care recipients and our clients. But as it continues to progress, then we go down to binocular vision, okay? So y'all look at that, man. Wow, your peripheral is even more narrowed. I mean, just look around. I've got to turn to be able to see things. So our peripheral is narrowed even more. That's more in the mid stage. But guess what happens? It gets worse, right? We get down to when we have a binocular, I hope I've said like a monocular vision. So we have one, and I want you to try this too, because our depth perception also changes. So there in your office, close one eye, whichever one you decide. I'm going to do close my right and open my left. I'm going to look down at the floor, and then I'm going to reach down for it. And you're going to be able to see the depth perception. So that's why it is so, that's why it is dangerous for them bending over to pick something up. My depth perception's off. I can easily tumble because I can overcompensate for the depth. I can just get off balance, dizzy, all kinds of things happen there. Also, with that, it comes into play too, our vision with rugs and flooring. When a floor changes texture, so maybe we go from a dark hardwood to a light carpet, we may not be able to tell that there's a difference. And, already with, if we're in our later stages, our gait is starting to change. We may be starting to shuffle a little bit more. So it's easier for them to be able to stumble or overcorrect. So they may think they're stepping into a hole or something that isn't there. So they're overcorrecting. Their depth perception is off, and they may fall. So those vision changes are crucial for us as professionals and caregivers to keep in mind. Another thing related to vision changes, and later in the stages with dementia, colors are a little bit harder for us to recognize. So a lot of us have white plates. But when we're feeding someone with later stages dementia with a white plate, that's a problem because they're looking down at that table, and maybe your table's white. And you're like, okay, I don't see anything. I don't know what you're talking about. There's nothing in front of me. And you've just set down a plate in front of them. So a tip for caregivers is to put a colored plate, a solid colored plate. For men, blues and greens are a better color for them to see. For women, it's more not purple. It's pink and orange colors, more bright, vibrant colors for them to see. So, by placing their food on a bright plate, they may be more likely to see it as well. So those are vision changes that we've got to keep in mind. Also, and you can, y'all try this as well. Forward facing is social vision, okay? And then downward facing is task vision. So I have to be mindful too that when I'm like, oh, look, well, and I'm getting them to switch their viewpoint, their brain is going to get jumbled when we do that. And what it does is it just causes confusion. They have a hard time switching between social vision and task vision. So it's another thing to keep in mind. So how we interact matters so much. And this is the meat of the presentation. This is what you're waiting for, I'm sure. It's also in your stance. Okay. So I have these two sets of people up here. And this is what we call confrontational stance. So these are nonverbal cues. We are squared up with each other. And what this does is this causes the other individual maybe to go on the defensive. You can see on this slide, the one gentleman has his arms crossed. He is definitely not wanting to be approached. So your stance matters, and how you interact with that person does matter, because unintentionally what we do is we send off those unintentional verbal cues, or excuse me, unintentional nonverbal cues is what we do with our body language. So, all right, the keys to the physical positive approach. All right, here are our keys. Our keys are the following. We need to get into their visual range. So for us to do that, we need to be at least in their visual range, at least 6 feet in front of them. Okay. We're going to start out by getting in that visual range. Remember, they may have monocular, they may have the binocular vision. So we want to place ourselves so that when we get their attention, they see us. We have a video showing that as well. So remember, 6 feet out is public space. And I guess, with COVID, we've heard about the social distancing of 6 feet, because that means we're not in people's personal space. 3 feet in, almost double arm length, is what we call our personal space. So we want to be invited into this personal space. We don't want to just come on in and bust up in their personal space, because remember, this can make them agitated. We can get hit. There's all kinds of things that happen there. And then past the 3 feet, when we actually get to the person, anything above their knees is called their intimate space. So we definitely need permission to enter into that intimate space. And this is our way. So her steps for this positive approach: get in the visual range, knock and announce yourself. One thing too that you can, I don't know, it might be hard to see, but I have my name tag on, and it's on the side that I have my, that I would reach out to shake someone's hand. And the reason that is, even though I'm going to announce myself, I'm also going to give them that visual cue. So what they're going to do is their line of sight is going to go right up my arm and hopefully to my name badge if it's placed correctly. So, hi, it's Claire, and they're going to follow up and see that as well. We're going to move slowly, offer our hand in the handshake position, and then we're going to move from the front to their side. And that is what we call a supportive stance. That supportive stance also is not intimidating, so we're not in our confrontational stance. And also, it's the most effective when we're on their dominant side. So, it's important to know what is the dominant side of the person you're taking care of. We have a lot of lefties out there. So for a left-handed individual, it's not going to be comfortable for you to be on their right side. Most likely it's going to be more on their left side. So we have to keep that in mind. We greet with our handshake and our name, and then we slide into hand under hand. And I'm going to show you that. But you can see the picture up here. This is the hand under hand up top. We're going to be friendly with a nice comment or smile and give a short, simple message. So I have a wonderful video of us doing this that I'm going to show you.
Lonnie. Hi, good afternoon. Hi, I'm Claire. Hi. Oh, you look very pretty today. Thank you. Yeah, I really like your shirt. My shirt. Yes, I like that. Pretty. Who got that for you? My daughter got that for me. Oh.
So one thing, always when you're watching yourself, you can always see things that you do incorrectly. I will say that on that video, I probably needed to be a little bit closer before I reached out my hand because she was bending a little bit forward. But again, it takes practice. I have been a coach since 2015, and it does take practice to be comfortable with this approach. So do not get frustrated if in 2 weeks you're like, I don't know, I'm just going to throw this all out the window. Do practice, because like they say, practice does make perfect. And that is what we're going to practice, that hand under hand. Y'all got off lucky, because if we were in person, we would be doing this with each other. We would be practicing our hand under hand. It's almost like a secret handshake. We come in, shake, slide, and there. The person that is doing it, if me being the professional or the caregiver, I want to have my hand on the bottom. And I want the person that I'm doing this with, I want their hand to be on top. And the reason for that is we give them the illusion that they are in control by us doing this. Okay. Also, a key that I need to make sure that you know this is not to pat, but just to place your hand. It's very hard for me. That was one of the things that I struggled with at first. I don't know if it's my Southern roots, but I wanted just to pat them. But you shouldn't do that. And the reason is because the skin can get very thin over time. The veins have a tendency to pop out a little bit more, so it can be tender. And then, also if you're taking care of someone that has, brittle bones, you can easily have a stress fracture or something along those lines. So again, I want you to see this one more time. The key is like that spin on the thumb. So that is where it's kind of hard for me to do, but you hit on the thumb and you spin, and that's the key right there. So let's watch that one more time for you to kind of see that. Shake, alternate. So this is a wonderful tool to help you. You can also take this tool and expand it and do this to help someone walk. I hope we have a lady that here at work. Hope she doesn't mind me sharing this, but she's having a little bit issues walking. She's having just some little bit of vertigo, and she will come up to me and be like, Claire, I want you to help me get to the bathroom because we have to support, we have to help her just to make sure that she's safe. Even though she's a trooper, though she comes in even when we are like, stay home and work. She's a trooper. She wants to be here, but she wants me to do this because she feels more stable. And this is going to be a great example of how to help someone ambulate without doing it the traditional way. So I'm going to play this and let you see what they're going to do. So they've done their handshake. She's got her there. She's placing the other person's elbow in her elbow. She grabs hold of the other hand, and you can easily see that she's able to walk with her. Let's play that one more time. So handshake, she turns, she puts her other, takes hold of the other hand. And this is actually a more stable stance for them to be in rather than grabbing hold of their arm and dragging them. How many of you have had anyone ever help you in ambulating? I had an issue with my leg not too long ago, and someone helped me up, and they grabbed me by my arm. And the reason we don't want to do that, even for younger individuals, is that is a sensitive area. You've got a lot of nerve endings there. I'm going to brag on Terry. Terry, I did this on her, and she has amazing muscles. Let me just tell you, there's no flab like me. That's why we don't grab there. And then also, we're taking care of older individuals. We could bruise them. This is a more steady way of being able to walk them. And also with this stance, it's easier to, if they were going to fall. I could easily slide in behind her and slowly lower us to the floor, easier than I could if I was in a different stance. So this is a game changer for you all. And then to expand even more on this is eating. So here we have. Our coworker helping her to eat. So they're in their hand under hand, and what she is doing is exaggerating the dips. She's exaggerating the dips and bringing it up. And underneath, you can see that she's supporting her at her elbow. So you want to, depending on that person's mobility, you want to either support them underneath the elbow when you're helping them, or on their shoulder to help them with that mobility. So what you have done is you're in that hand under hand, and you have the spoon in your hand. But what you're doing is you're tricking their motor memory into that movement of eating. Again, I wish we were in person because I'd have you all try this, but it's a lot easier than grabbing hold of their hand, putting the spoon, and then trying to get it up to their face. You can literally feel the resistance in people when you try it that way versus the other. So keys, keys for us to remember in our approach. And this is a great example too. On this, like with Sarah being, this is my coworker, Sarah, when we were approaching her again, as a reminder, we wouldn't come from the back because remember her peripheral. That's why we have Vicky, our other coworker, at her side and on her dominant side as well. Okay. Final thoughts. All right. So bringing all of this together, how does this play into you in the positive approach? It plays in because what we have to do is we have to work around that person's brain failure and work with what skills they have left. A lot of times that is just some of our motor memory that we're using, especially in these later stages. Also, one thing to point out, when I gave the example about the binocular vision and the strength and the lady grabbing hold of that worker's breast, we also have to keep in mind their vision. Because what we do is if we walk up to someone and we're in their intimate space and they're here and I'm up here, think about their line of sight. It's going to be here. And for men, this can, they're like, ooh, what is that? And they may not recognize that that is someone's breast. They may think, ooh, that's nice and fluffy, and I'm going to touch it. And then they touch and they feel the sensory, and then sometimes that, or not sometimes, that can also lead to them being labeled a deviant and a pervert, and it's not intended. What happened was it was that person that evoked that reaction out of them. So remember, we can remember because we're not dementia, and we're not in brain failure. So that is a key for us to remember, is just our approach matters. Also, in life, I told you that, when you have those changes, new data reminds you of old data, but then with dementia, it gets confusing. So, a great example of a person acting out in a nursing facility, they had this gentleman that used to be an airline pilot, and they would bring him in and set him in the dining room, and behind him was a picture of a Boeing 757. And every time after that, after dinner or breakfast, he would get agitated, and they're like, "What is going on?"